to another episode of the Sports Medicine Project. Kelly, how you doing? How's things?
Yeah, alright.
All right?
Yeah.
How's the
alright.
week? Good week?
Good week, kind of. Yes and no.
Yeah, I mean, let's kick it off. I mean, we've got part 2 of our episode with Nikki Manvell, again, talking proximal hamstring tendinopathies, and our second most popular episode off the start behind Michael Niski.
Really?
Yeah.
Oh,
yeah.
cool.
You need to start checking the numbers.
Yeah.
I'm telling you.
I'm not a numbers gal.
Yeah, the data is everything these days. It was good. So
Actually, Joe Skipper was talking about data and what was he saying? He was like, the one thing that I want to be able to see more, this is a bit irrelevant, but the one thing I want to be able to see more of in like triathlon races and just general races is like data. I was like, that would be cool.
Like how with the marathon or with any kind of racing
like
where they show their pace.
Or like triathlon, like their power output in a cycle. I reckon that'd be cool.
Yeah, it's a bit difficult.
Just after today, I'd have such a... most of them would have power meters, I reckon.
Yeah, but then how would you
Back on the Zwift, my 155, I was dying.
You could, but then how would you have that meter, everybody's meter, projecting to some system to then identify it? Yeah, well, say if you got 20 elites, then you've got to somehow, like, how is it going to get there? It has to be through cellular data because Bluetooth wouldn't reach. You know? So if you've got a power meter and you're 180 kilometres or 90 kilometres away on a triathlon, it's got to project all the way back to the hub of the technology to then send it out on the TV in real time. It'd be a huge ask, but it'd be awesome.
That would be cool.
It would be cool.
Yeah.
I know they can do the
You're
pace,
a bit of a
which is good.
logistics man, aren't you?
I'm just
like, that
a realist.
sounds cool.
Yeah.
I want it to happen.
It would be awesome. It would be awesome. What I would love to know is during the race, I'd love to know the percentage the foam compressors on each strike. That would be pretty cool to see.
It would be different.
What do you mean?
For each person.
Yeah, I know. I want to see everyone's individual.
How would they do that?
I don't know.
See, that's something that I can't understand.
Yeah, well, you're saying these things can just happen. They just put these little measurements on the phone.
Or maybe they could put like a, I don't know, something on the bottom of your shoe that says how much. Like when you go into athlete's foot and you walk on the thing and it goes like
bring up
the colours.
Don't bring up athlete's foot. Come on, we're having a good weekend.
But that's kind of the same thing.
Yeah. How they get you walking on the what do they call it? It's called something
shows
now.
Shows pronation.
No. Oh yeah, it does show. It shows. Oh, I've heard some horror stories from there.
Where the pressure
the
pads. The pressure pads.
My 3D Fit Scan.
Is that what
or whatever it's called, where they walk on and it shows you where the pressure's going, and it's like, well, there's so many. I don't know. Some people are really good there, and I don't want to talk about athletes put in a bad light. I've just had patients that have reported some horror stories for me, but then again, I'm sure patients have told some horror stories about me. I just don't like the importance they place on all the technology when it's probably not that important. And they give inner soles. That's the other thing. They give inner soles when they aren't indicated. But then again, so do podiatrists, so I can't get too angry about that.
Didn't you say like an off-the-shelf
orthotic
is sometimes just as good?
Yeah, and this is when we talk about off the shelf, like they're
still modify it.
Yeah, they're semi-custom and they're medical grade. They're talking just like a slim pass of foam. Not even foam. It's like leather. I don't even know what it is. But then again, some people have probably got the results from it. You started me on, and then we're going to start talking about the Good Feet store. Let's just
let's cap it at that.
Yeah, cap it. So how was your week? Good week? Highs and lows?
It started off good. So this time last week, I was carrying on about my PB. And prior to that, I said, I'm going to have a week off running after Blackmores.
Yeah.
Just a skeletal reset, as Stuart Warden likes to call it. But I got carried away, and then I ran 13 Ks at like 5-minute pace, which is a fast run.
Tuesday.
Yeah. And then on Wednesday, I ran in the morning and in the afternoon again, a little bit faster than I probably should have. And my shin has flared up for the first time in about 12 months.
Yeah.
The other side to the side that
and
I
when
had
you
the
say
bone
shin,
stress
whereabouts?
injury.
So when you
medial
say
tibia.
Yeah.
Medial tibia. So I had a bone stress injury of my tibia last year. It was on my right side though, and this time it's on my left, which makes me a bit more optimistic, but I'm a little bit down in the dumps about it. So I've gone full like patient mode, and I've started stretching like mad and getting the tennis ball into it, and then even came to you for Shockwave.
Yeah.
And I was planning on having just 3 days off and trying to run today, Sunday, but hopping was painful. So I've decided to give myself a full week off, maybe 10 days even, which hopefully just settles the dust. I'm hoping it's just, it was a big spike in load. Not necessarily load, like overall kilometres were less, but the intensity of my runs were higher, plus just coming off the back of a cold and things like that, I think might have contributed
poor
to
sleep
this.
in there.
Poor sleep. So flare up of my shin. If it was a tendon, I'd just probably run through it a bit and be a little bit less concerned, but I do take anything bony at like quite seriously, I guess you could say, and I just try to avoid pain at all costs with those ones. So it's gotten me into a little bit of a
and we always talk about bone conditions, bone pathology sitting on a continuum, which I guess most pathology does. And down one end is stress fracture, and down the other end is healthy bone. We're pretty confident, or even you were saying you were pretty confident, it's probably more a bit of periosteitis inflammation than an actual pathology to the bone itself. So that probably indicates not as long as a recovery time, but still you've just got to recover, unfortunately, and any loading, and it's more the intensity which increases the peak ground reaction force, it really flares those things up.
I don't think it's anything like stress reaction. It's quite a vague type of pain. So on the anti-inflams, avoiding any really load-bearing stuff at the moment.
If you were a patient that had this, what would you say? Would you give it a similar recommendation, a week or two off, and you would explain to them it's probably, or it's likely it's not as serious as a stress reaction or stress fracture?
I think so, based off...
Someone unknown.
Wow, that's such a weird sound. Based off the literature that I've read, if you try and run through pain like up to a 4 out of 10 with MTSS, there's a study where it took like over 100 days until people got to 18 minutes of running, which is so long. I just think it's better to just give it a rest when it's super acute and see if you can just settle it down and then gradually reload yourself slowly. Yeah, you're right, 100% right. And it can be really difficult, and that was one of my lows for the weekend, was seeing a patient with an injury and really delving into not just their biomechanics and the pathology, but the impact this injury has or will have on their life while they're recovering and all the things that they can do. So they were quite a social person, doing running and playing sport and touch footy and things like that was really important to them. And seeing the impact it will have on their life for the next 4 to 6 weeks just goes to show that there are so many other psychosocial things that are attached to people's pathology, and sometimes it's not always your job and you don't have to delve into all those things, but just understand it's not as easy as saying, hey, just rest, you'll be fine, it will get better, because it's likely that it will, but you're not the one that you might be seeing them a couple of times for 30 minutes in 6 weeks, but they're the one dealing with this injury, missing out on things they love, and it can really have an impact on their life. So and that can then play into their experience of pain, how long the injury takes. So, just be all encompassing of people. Totally. Like, I'm a hardcore catastrophizer. I'm the first person to admit that. And I would say I have a very low pain threshold. But also...
Yeah, you too.
I totally get that though. Like, I don't think I run at all on my own, and I think that's part of the problem. Like, every single run that I do through the week is with a friend or group or something like that. So that's a huge knock to the social life, really.
Yeah, definitely.
But I also think, as I was saying to you before, I think that's part of the problem, is that a lot of my runs are influenced by the people that I'm running with, rather than just doing my own pace and my own sort of recovery runs. So that's probably something that I need to be more aware of as well. Yeah,
and whether you just need to be aware of that in the short to medium term, while you do have a really strong, consistent period of loading, and you do build that capacity to then be able to run 5s, 450s and recover. Yeah, but also, we always talk about how common running injuries are. Some studies show up to 79% in 6 months. Like, that is almost incredible. So I think as a runner or as an athlete or anyone that plays sport, you will very likely suffer an injury sometime in your career or pre-season. So you've just got to be have an understanding that these things will happen. It's just a part of what you do, and that's, you get the enjoyment out of it, and this is just the bad side to all injury and pathology.
Totally. Well, I'm gonna try and build my love back up for the Zwift, which I think is going to be an impossible task.
Oh, it sucks.
But swimming, I do enjoy. So I can swim and gym. Yeah. And hopefully it's only for like a week or 10 days.
Hey, what about, actually, we've got Nikki coming on obviously for this episode. What did Nikki suggest about being in the gym? Because I probably, if it was a patient, I would have suggested something different, and it's always awesome to learn. And she has so much experience. But yeah, what did she suggest for this week?
So I've been talking to Nikki, who is going to be talking to us about proximal hamstring tendinopathy in a second. But I just think, and this is relevant to everyone listening to this, if you're a physio or a podiatrist or any kind of
chiro, osteo,
anything,
diesel mechanic,
if you get injured, just talk to someone else about it. I really think there is so much value in that.
Oh,
someone
as in
else
the patient or the health professional?
Like, I know how to manage medial tibial stress syndrome, but I can't manage it when I'm the patient. Like, I go a bit crazy, I think.
Yes.
So I feel so much better just asking someone else and really having another clinician treat me. Yeah. I think that there's so much value in that. 100%. Yeah. You came home, I was rolling on that tennis ball for like the last 30 minutes.
I come home, come in, and so our house is designed where you walk in the door, you look to your left, and there's our lounge room and TV. I walk in, and Kelly is on the tennis ball, massaging it. Far out. I almost threw out the window. I thought, what is this crap? What are you doing?
Sometimes
I understand, and you know that I completely understand that, yes, if it feels good and it's a short-term pain modulator, and if you understand the narrative, it's fine. But for something bone, logically, that should only make it worse. And you know that, do some calf raises instead.
Well, funny you say that, actually. So because it's an acute flare-up of symptoms, Nikki has recommended to just stay off any load-bearing activities. So that's calf raises, walking, squatting, deadlifting, lunging. Just let it calm down as much as possible without just putting any extra stress on it. If it was more of like a chronic on-off situation, then that's when there might be some merit to loading it a bit. But when it is that acute flare-up, it probably does just need a short rest.
Yeah, you're right. Yeah, so I'll finish that off with my low was basically seeing that patient and having that discussion and just, seeing all those things in their personal life, which, it always happens. It doesn't happen all the time, but every so often it happens, and I think to myself, as a clinician, especially a younger clinician or a student, you don't learn a lot about how to manage the psychosocial aspects of someone's life, but just being aware of it, I think, is important. And then also not saying to them, hey, your stress levels make your injury worse, but, just kind of, I guess, not wording it in there. I always love the cup analogy, and I just draw it into the cup and go, hey, this is something that does this does change your experience of pain, and it's important to understand, and I kind of move on from it. How do you talk about stress?
Oh, that's hard. Yeah. It's going to depend on the person and I think their personality type, and the context of how it's sort of coming up. I probably bring more relevance of it to it when they do bring it up themselves. I don't know. That's a hard question to answer. I think it's really going to depend on the person and their situation.
Yeah.
Sorry to be a bit vague on that one.
No, you're right. It is these questions. It's better to be vague and then tell people that stress makes pain worse.
Yeah, I don't think that's the way to do it.
No, definitely not.
I don't think just I don't know.
But I think there's some value in them being aware of it because they, I love, and maybe that's just my bias, I really like when patients have an understanding that there's multiple factors that contribute, one to their pain and one to the injury. And actually, that's probably another low for this week. Had a lovely patient who had heel pain for a couple of years. Lovely lady. She just come in and said, it's because of my weight. I'm overweight. And we know that BMI is implicated in lower limb pathology and especially in heel pain. It's one of the two risk factors. One is BMI, one is having a heel spur. It's been identified to be a risk factor for plantar heel pain. And when I was younger, I was very much afraid of saying that it's a contributor, but, we did end up talking towards the end of the consult that, yes, her BMI does play into, the pain at the moment and likely a contributing factor to the injury. However, we don't know how much. So how much is it worth focusing on? Let's just focus on the things we can, and that's, modifying your load, soft, comfy inner soles, heel lifts, good shoes, some strength and conditioning, that kind of thing.
I think having thought about that a little bit more now, I think what I tend to do is kind of ask the person that, ask them if they think it affects them. So if I'm sort of going through their subjective history or sort of talking about the cup analogy, and I sort of say to them, if they say they've been a bit stressed with work or work's been busy or something like that, I sort of say, do you think that there's any contribution of that with your pain, or do you notice if when you're feeling a bit more like this, your pain is worse? And I actually feel like more often than not, patients are like, oh, yeah, maybe a little bit, actually. Yeah. Now that you mention that, I think I do notice that. I think I do it more just to get them to reflect on the fact that other things could be contributing. And that's probably more so in that initial consult where I'm not going to just vomit a bunch of information onto them that they might put their wall up against. It's more so just sort of asking the question to get them thinking about it. Yeah. And then later down the track, I might draw a little bit more attention to that. It's tricky.
Yeah. And you're right, and you're so right. Picking the patient, knowing when to do it, and usually doing it multiple times as well. There's nothing more frustrating when you really explain something well and you think you've got this really good patient, practitioner alliance, and it's completely normal, and you come back the second time and they just say the same thing, and it's like, well, that's just how it is. You can't expect your patients to take in everything that you say. What's the statistic now in taking 11% or something like that? Yeah. Anyway, so I'll quickly end with my high, which was, I don't know if I want to bring it up now, which was running 83 kilometres this week, which is the most I've ever run in a week. And, and I feel, I'm talking about a marathon build. I've only been doing it for probably 3 weeks now. And this week, I hated running. Monday to Friday sucked. I think it's been really busy at work and the uni and podcasts and things like that. So just trying to squeeze in some running. Got the kilometres done. Hated it. And then Saturday went for a run with Nikki, easy 13. And then today did a 25k long run. And I'm back. Frothing it. Yeah, it was so good. Body felt good. And and I've heard people say you have those kind of ups and downs. But, on the Inside Running podcast, they say that and I'm sure people that build for marathons know this, there's times where you just feel really crappy and you feel really down because you're loading so much. Yeah. But it was awesome. That was a great weekend of running.
Yeah, you've done well. You've had a great run today.
So that was a good high. And the other high was the uni has I teach one day at Wyong Hospital and then on a Friday. But at Wyong Hospital, we now have a dedicated, with the students, biomechanics room where we've got 3D scanners, we've got a treadmill, beautiful big room. So anyone with pain, discomfort, come down to the student clinic. It's Tuesday preferably because I'll be there as a supervisor. And I think it's $25 for an initial consult and it's an hour. And it's bloody awesome. So that was really, really fun. And it's good to see we're really trying to get UON spearheaded in the biomechanics musculoskeletal world and trying to teach some better rehab and orthotic prescription and patient questioning, just awesome stuff. So that was really great, and it really is rewarding to see the students so happy down there learning that stuff. Yeah, which is cool.
My highs, I've got 2. I'll be quick.
2.
First one.
No, you take your time.
First one.
All right, thanks for the Go.
First one is we're about to watch Berlin Marathon, and I'm feeling super optimistic that Kipchoge is going to do sub 2 hour marathon. I've got a $50 bet going with Joe, and I reckon he's going to do it. I'm feeling it. I'm thinking he's going to channel my excitement for him.
Yeah.
Channel my tibia.
Go.
Second one is I saw a patient this week on Wednesday with a really acute, nasty flare-up of low back pain. He couldn't even walk into the clinic. He was walking in hands braced against his thighs. It was really, really bad. Nerve pain all down his leg. came in and he was like, I think I need surgery. He's got an appointment with the specialist this Wednesday, spine specialist. And he's like, I can't like deal with this pain anymore. It's just horrific. I think I'm going to have an operation on this. I think they're going to have to fuse my spine.
This is common.
Had
too.
a really good.
This happens a lot.
Yeah, I mean, I haven't seen a nasty flare up of low back pain like this guy has had in a while, to the point where it's just so irritated you can't even assess anything or do anything really. Like, most of it was just a conversation on education around it and trying to de-threaten the problem. And then I saw him again on Friday after just, not saying that I'm like magic, but I saw him on Friday. You sold yourself short.
You change people's lives as a physio.
And he came in walking and he was like, I listened to what you said and I started doing some exercise yesterday, just getting it moving, doing all the self-management strategies to try and make it feel a little bit better. And I feel like I've, turned a corner today. I feel really good. I can walk. Like, I'm starting to get a bit sore now, but I'm now so much more optimistic that it can get better. And it was just really like one of those patients where you're like, wow, like you thought you were going to have a fusion, like you, and maybe you would have, because it was just that unrelenting pain that would not change. And, I feel like I really helped him. It was a good feeling.
Great. Awesome. Well, yeah. That's good. Well, let's leave it there and let's finish that off. And everybody, enjoy this lovely episode with Nikki Manvell from New You Moves, Proximal Hamstring Tendinopathies, Part 2. Kelly, anything to say before we leave these lovely listeners for a lovely episode?
No, I just really enjoyed this episode, as I did the first one, and I think you'll all get lots out of it.
Awesome stuff. Catch you later, guys. Have a lovely week as always.
What about if you think there's like a bursitis involved?
I think that's the one. I think that is the time when it does get more sensitive to touch.
Yeah.
I have seen a case of a bursitis where I've palpated it and been like, oh, that's really tender. And the person ended up having like a big florid tendinopathy with heaps of fluid around the outside of the tendon and a big bursitis, and they responded quite well to just a cortisone. So they just cortisone in the bursa around the tendon, and it just...
When you say fluid around the outside of the tendon, like can peritendinitis happen in proximal hamstring tendons?
Yeah, I don't know if it's called. I don't know if it's the same type
as like an Achilles.
But essentially, yeah. And I think that's that whole frictioning thing that I spoke about earlier. I think that's a similar case, and it's what's reported on MRI. So the imaging modalities. Have I finished my... I don't want to keep skipping topics, but I think I'm pretty much finished my examination component. But the imaging comes into this importantly as well, because a lot of people do bring in imaging. They bring in, I've had an ultrasound, I've had an MRI, I've had this, I've had that. And what we know is that as people age, hamstring tendon changes are so common. And I think, again, it speaks to the anatomy. If you get a tendon and you wrap it around a bit of bone and you get people to sit on it all day and load it all day, and it's going to change. And tendon changes and fluid signal around the tendon, bursal signal around the ischial tuberosity, it all, and fraying of the tendon and partial tears and stuff are hugely common in the general population who don't have any symptoms.
Yeah.
So sending someone for an image to rule in a hamstring tendinopathy is pretty useless. Potentially sending someone for an image if they had that complex case of a bit of deep gluteal pain, bit of low back pain, bit of SIJ pain, bit of referral down the leg. It's a bit confusing. All their tests are positive, don't know what's wrong. Potentially, like a MRI might exclude a hamstring tendinopathy.
What do you, and I know this, I think as it comes with experience, because you're probably pretty understanding of when what imaging is probably indicated. With younger clinicians, do you recommend them sending to, whether it be someone like yourself or someone that deals with hamstrings more, or straight to the sports doctor, or sending for an MRI? Because I know even the students at the university, they wouldn't feel comfortable sending someone for an MRI, which I know comes with experience as you become more confident. Are there any recommendations you'd give on that, or what would be your plan?
I think whenever you're feeling the need to send someone for an image, you have to understand what the appropriate imaging modality is, what its sensitivity and specificity is, how how confident you're going to be in getting the results back and knowing what to do with that person anyway. So I always say to a lot of the time I'm not the primary referrer for imaging. 9 out of 10 people that I send for imaging, I send via the sports docs.
Yeah.
And it's purely because once you get the result of that image, what are you going to do anyway? So if the reason I'm sending that person for an image is to confirm or rule out something more sinister or something more nasty, or I want to confirm a particular diagnosis that might be more challenging for me to manage, I'm going to need their help anyway.
Yeah.
And so a lot of the cases that I'm confident and comfortable managing don't need imaging. I sort of know what it is. I think I know how to treat it. I'm going to manage it my way without needing the image to confirm or deny what it is. And then if it's not responding to my approach, then I'd send them via sportsmen to have the imaging done.
Yeah. Yeah.
So it would be a rare situation where I'm sending someone first port of call. I don't know what's wrong. I'm going to send you for an image to check this.
Anyway, yeah.
I think if I was like, I don't know what's wrong,
get the doctor.
Get the doc involved. Get them to do their diagnostics, imaging, and then do a workup to work out what the best treatment is.
Yeah. So if subjective, objective done, you're confident it's a PHT, and we'll call it PHT. So we
just to save heaps of time.
Save time, but now we're talking about it, so we're probably wasting time. But yes, you've got a PHT. We're very confident. Educational points that you're giving are probably in the initial assessment and then following up. What are you telling them about this pathology and this tendon?
That's a big one. So I think my first consult a lot of the time with my prox hemi tendinopathy patients are, firstly, I'd give them a really big long-winded story about my own experience. No, I don't really.
Make it all about me.
I tell them all about my case study. No, I try to understand what their goals are to start with. So if this person's super hell-bent on smashing out a sub 20-minute part.
I was thinking, I didn't know, not many people will be able to do it.
No, it's only the few elite people in the room can do that. So if they have specific goals that require hills and hurdles and sprinting and stuff, I might have to dial that in a little bit and say, well, maybe that time frame might be unrealistic, or it's going to significantly be, you're going to have to put up with a certain amount of pain if you're going to do that. And then managing expectations within that setting. So if they're like, I want to be able to do this, okay, you can at some point. It's going to take time. All tendons take time. You can't rush them. The more you rush them, the crankier they get and the slower they respond. So I feel that, I educate them a lot about, days on, days off, and not smashing it every day, not doing too much with it, not doing consistency of training is the most important thing. They have to be super consistent. If they're not consistent, they're not going to get better, and they have to stick and trust the rehab process, and it will be in stages, and I sort of talk them through what the stages are and what they are to expect over the coming months, not weeks. This is not something that'll be fixed in weeks. It's often months, depending on how cranky it is and things. Some are just a quick flare and then you can give them appropriate advice and it settles down, but others that have been there for months, it's going to take months to settle. So a lot of education around that, lots of education about do's and don'ts. So I find the majority of people go wrong not avoiding the things on the don't list. So they keep stretching it, they keep poking at it, they keep sticking dry needles in it, they keep doing yoga and sitting on it all day, and all the things that I would say don't do, they're still doing those things. So they might be doing a really appropriate, well, not even a really appropriate strength program, but they might be loading their hamstring in the gym because they think that that's what they need to do, but they're also still doing all the really negative things to the hamstring at the same time. So you can't just do the positive things and hope it'll get better. You have to avoid the negative things as well.
I used to be don't stretch ever for tendons, but now in some cases I wonder if it is just sort of exposing them to an irritated load. Obviously within reason, I feel like patients think that stretching is the most important thing in the world, so they do heaps of it. So I feel like my conversation's probably more so about not doing it, but just not feeling like you should do it all the time. I don't know.
Yeah, I think that I would agree. I think that stretching is not the devil. It's just
a low value treatment.
It's such a low value and it's potentially negatively influencing their rehab. Like if they're gonna have a crack at doing it the best possible way, if they're gonna do every 1%er they can, stretching's a negative 1%er. Like it's going the other way, I think.
And what's it actually achieving?
What's it actually achieving, other than a short-term potential relief feeling that they get? So a lot of people, it feels good to stretch it. Yeah, it does, but it's squishing the shit out of your semimembranosus up against your bone. And probably pulling on your sciatic nerve, and probably doing this and doing that, and not necessarily making things better. You could probably, instead of stretching, how about you just dig the shit out of your heel into something and just get a good isometric for a little while? Or how about you just stand up and stop sitting on it and do this and do that? Like there's lots of things people can do in that positive column that are going to help them get better a lot more than the...
And that gives them relief as well. Like doing exercise or resistance training gives you relatively the same relief as stretching.
Yeah. I always say to my patients, like initially when you start these exercises, you're going to hate them. Like I fucking hate bridging. It is the worst. I hate it. I hate laying on my back and putting my feet up on something and lifting my butt up. Like it's the worst exercise ever. But after a while, like it gives you such a good relief. Like you stand up and walk away and you're like, I feel better for doing that. And you see improvements in your strength, and you can see that, I couldn't hold 15 seconds doing this 2 weeks ago, and now I'm holding it for 30 seconds. You see these improvements and you start to kind of crave, my hamstring hurts, and you're like, almost instinctively want to lie on the ground and do your rehab because it gives you that relief. It's the same with all the other tendons as well. You know, you get this really strong pain relief response from exercising the tendon. So
yeah.
And
then what about like deadlifts? What do you think about them?
The deadlifts are controversial. So I think that I think this is where people can go wrong, and this is probably another little clinical pearl, is in the assessment process, both in the history and in the physical exam, you'll get a sense of whether this person has more of a problem under stretch and tensile loading or under compressive type loading. And there's sort of a split that can occur in rehab where initially, so I think once you get to sort of that stage 3 component of rehab, so stage 1, or they talk about rehab in different stages for the proximal hamstring.
Let's go through that rehab those phases, because I'm sure that will come up in that.
So most rehab they taught for tendons, they break it up into phases. So like stage 1 would be your early isometric type holds in positions of next to no hip flexion. So it might be like a prone hamstring knee bend like hold. It might be like a heel up bridge hold or a long lever bridge hold. So they're all things where your hips are fully extended and you're just holding that position, digging your heel. And then you progress into stage 2, which is like your isotonic stuff. So it's either a heavy slow resistance or an eccentric type contraction. And again, depending on what the person can wrap their head around. So some people can't get eccentric, some people can't get the heavy slow resistance thing, so you just tailor the rehab to them, and I don't think it really matters. I tend to like a small amplitude isotonic, so they're just moving nice and slowly through that contraction and keeping it heavy, and then doing like a heavy slow resistance model where you work backwards from that high repetition, high volume stuff, and you get heavier and you drop your repetitions down. Then you'd move into progressive hip flexion angles, and I think this is where people stuff up. So once you're tolerating those little isotonic contractions and tolerating small amplitude, when you start to increase the range of motion at the hip, you can go a couple of ways about it. You can keep your knees bent and you can do exercises like squats and lunges and step ups and things that compress the tendon at the hip, or you can go more your rack pull, deadlift, single leg RDL where your knee is extended. So one is a very stretchy, tensile loady thing because it's pulling the hamstring at both the distal end and you're getting the compression at the hip. And then one, you're keeping the hamstring reasonably short but you're compressing the shit out of it at the hip. So I think that's where some people can go wrong. I think they might, if the person is intolerant to the stretch or they're having more issues with that tibial deceleration stretch component, and they're not having as much issue with the deep hip flexion component, if they introduce the deadlifty stuff too soon, shit will hit the fan. And then vice versa. If people are having more trouble with compressive positions, they might be better doing more of a deadlift, a slider, a arabesque RDL thing, and they might not tolerate deep leg pressing and lunges and those sorts of exercises. So that's the delineation I try to make with my rehab. I'm like, oh, this person looks like they're going to go this way, and I sort of tailor their rehab towards doing a wall sit and a wall ball squat and a squat and then a leg press and a lunge, and work them up that way, and hip flexion, but I keep their knees in. And then other people I kind of start to extend their leg out further and do more of a slider type RDL stuff.
Do you then progress those groups into the other thing that you're not doing
100%.
like after?
They do like a crossover almost. It's like once your hip, once your proximal hamstring tendon can tolerate the tensile pulling lengthened position, cool, now let's squish it into a squatty type position. Once you can tolerate the squat, now let's sort of deadlift on it. Definitely I try and do a bit of a crossover, but I think that's something clinically that I find. I feel like if you can make that delineation, that can be helpful.
And do you think that that's more for managing pain, or to get them to be able to do like their activity, or do you think that it's a bit of both?
I think a bit of both. I think, trying to load the tendon so that it will sort of sort out its pathology. So I think if one that's not tolerant to compression, and then we compress it too quickly, it's just going to blow up. I think compressing it at some point is necessary to allow it to adapt to compressive load. But I think if you do that too early in the phase, it's going to get cranky. And I think that might also be a trial and error thing as well. So you might introduce some deadlifts and the person's hammy just goes, oh shit, I can't do that. So you go, cool, let's just maybe do some squatting and lunging and stuff instead for a little while, and not progress the length of the hammy too quickly. And then stage 4 is your faster stuff. So it's your energy storage release stuff. Now, I don't think it has to be linear like that.
No,
I smudge it. Smudge it. So stage 4 is smudged into stage 3 for me. I don't think there's any reason someone can't be doing little fast movements in a short range. Like there's no reason you can't do little mini bridges quicker if you can tolerate doing them slower and heavier while you're doing your other higher compressive stuff. So I do a bit of a mixed bag there. Same as my Achilles as well. You don't just do heavy slow resistance, but you might be doing some little skipping and hopping exercises as well at the same time. They don't have to have nailed all of this stuff in stage 3 before they progress to stage 4.
And then what are you saying to patients in regards to pain? Like how much pain should they be experiencing, if any, and how do you help them understand that?
That's really tricky. So I used to always talk about this 4 out of 10. You should expect it. I always say that the exercises should be painful. I think if they're not giving the person some discomfort, potentially they're not hard enough, unless it's later, obviously. So if they're not feeling the pain at the time and then afterwards they feel it, that's obviously normal. So I think pain at the time or afterwards is expected. If it's no discomfort, the exercise needs to be made more challenging. So that's something that some patients don't like. They don't like pain, and they're here to see me. They want to see me to get out of pain, not to get in pain.
And that's where then managing expectations
comes in. The other thing is the response, that 4 out of 10, everyone's like, what's a 4 out of 10? So I've sort of moved to just talking about discomfort and tolerance. So it should be uncomfortable, it should be tolerable. If it makes you modify your day significantly, like if you just can't sit for the rest of the day, if you're shifting and you're uncomfortable and you can't sleep and it's like you need to reach for pain relief, you've pushed it way too hard. If you're limping, or if you've pushed it too hard, you'll know about it. So if it's comfortable, or if it's uncomfortable but tolerable, that's usually the words that I use, and then it should settle within a 24-hour period. So if you've aggravated it on the Monday, by the Tuesday arvo, it's like gone and it's okay again. And then that's important about dosage as well. So in the early stages, when you're in that stage 1-2 phase, often people are doing those exercises quite often. So they're doing them most days, sometimes twice a day. And then as you progress through those stages of rehab, you're doing them far less often. So that's when people plateau out and they start seeing that their recovery is not happening as quickly. But it just needs time, because you can't hit super fast, speedy stuff and super heavy, slow stuff and have these hectic, big gym programs and hit them every day. You need to do them like 2 to 3 times a week.
And then if they're still running on top of that as well.
Correct. And I find that sometimes doubling up gym and rehab on the same day is better than trying to space it throughout the week, because then people can actually have rest days rather than having gym on Monday, run on Tuesday, gym on Wednesday, run on Thursday, and it turns out they haven't had any days off in their week. They need that rest. So,
what do you say to the adjunct therapies? I know you and I have a bit of a gripe about Shockwave. I love it.
You just have a rager about Shockwave every time we talk about
Only because, and even Jill said yesterday, Jill Cook said to me and also the crowd, I don't know which one she was addressing.
She was making eyes at you.
What actually happened, I thought that she was going to say it's good because the research is good, but she's like, I don't give a crap what you do. If it makes them feel better and they leave with an active rehab program, I'm happy. I was like, come on, Shockwave's a little bit better than that. Yeah, give me a little bit more. Yeah.
So the current evidence, from what I understand currently around Shockwave and proximal hamstring tendons, is that a randomised control trial showed that it was more effective than multimodal therapy, which included exercise, massage, anti-inflammatories, bits and pieces. Now, if you dig deeper into the exercises, it said the exercises included a hamstring stretch, cycling and lunging for 3 weeks.
Yeah.
So, I mean, take your Shockwave and shove it, or create a better trial.
Yeah.
So was the Shockwave group just Shockwave alone?
I think so, yeah.
Yeah, right.
So, and I think that...
not that those exercises were helping
no,
anyone's hamstring tendon.
I just don't get. Anyway, they need to do some sort of big trial looking at Shockwave versus sham versus Shockwave
and exercise and Shockwave versus just exercise alone.
Correct, yeah, and design, and this is the whole research and practice network thing that we're trying to establish, is going, right, well, that study was useless. Not useless. It gave us some information, but if you had I sound awful. If you have experienced clinicians going, well, let's design a rehab process that we would practically actually give to someone with a proximal hamstring tendon pain, design that. It's not going to be a 3-week program. It's going to be a 3-month or 6-month program. And now let's see if the addition of Shockwave is, improves these people's outcomes or not. So
if it did, would you come see me tomorrow?
Yeah, I'd send. Yeah, 100% if it did. But again, my hamstring might be different because I'm a rupture. So.
It's interesting though, like, because everything that we've just discussed is that compression hurts a lot of the time, and it's something that aggravates symptoms. It doesn't really make much sense as to how it would feel good.
It does though. It stimulates free nerve ending to the point of numbness, and also through revascularization, so more blood flow. But whatever.
Well, that blood flow arguments.
Whatever.
Like do some jumps or something. Like that'll help blood flow.
Or just stop sitting on it maybe. That'll improve blood flow as well.
And other
other than Shockwave,
cortisone, PRP.
Yeah, so cortisone, PRP, they needs more evidence, but clinically, I see that the recalcitrant cases that don't seem to be responding to much do tend to respond to either like a peritendon cortisone. If there's, again, that's where the nuances of sports medicine and looking at imaging come into it, but some of the ones that have some of that peritendon signal and swelling, often they respond to like a peritendon injection of cortisone just to settle it. And then the PRP is similar. So the PRP into the tendon, they'll have those 3 PRP shots spaced out a couple of weeks apart or whatever it might be, and they seem to, I don't know what it is, but it sort of like hits a reset button for that person's. And I don't know if it's like because they've invested the money in having the injection and they've bought into it and they dial into their rehab more, or whether it actually does.
Because this is all happening while you're doing rehab as well.
100%, yeah.
And how often are you dry needling people with hamstring tendon?
Never.
No condyle packing or anything like that?
I don't need No. None of that.
Why?
No needling. Why?
Yeah.
I don't have a dry needling certification for one. And 2, because I don't think it would.
Doesn't change the capacity.
I don't think. Yeah, it doesn't improve tendon capacity. So I'm all about that. I think that if people want pain relief, cool. Like that's not what my remit is. I'm not a pain relief specialist. Like if you want pain relief, there's a million people with shingles up that can give massages just as good, or if not better than me. If you want a massage, go get it somewhere else. Like as a physio, I'm skilled at giving massage, but I'm more skilled in knowing when massage is indicated and when something else is indicated that's more effective. So
Yeah.
What far out? I feel I was going to say then. Oh, it was something about massage.
I still want to ask about this peritendon thing.
yes.
Because management for the peritendon in the Achilles is like the opposite to managing a tendinopathy, where you'd rest it more so, right?
Yeah, I don't think we know enough about the peritendinitis type case in a hamstring tendon. I don't think that's the same. I don't think it's the same. What I'm talking about with it's still more of a chronic case of a sheathy inflammatory signal thing around the outside, and that might just contribute to more tendon thickness and stuff. And it seems to respond to some cortisone, but I don't know if necessarily just getting that person to rest would do the same thing.
Okay, that's good to know. And what about anti-inflammatories? Are you encouraging people to take them?
Depends. Technically, we're not supposed to
Yeah,
encourage people to take anti-inflammatories, but if it's a acute reactive case and the person's got constant discomfort or they've flared the shit out of it with a recent event and they're just shifting in their chair, constantly uncomfortable, they're almost limping to walk because it's that cranky, then I think there's probably a place for a short course of some anti-inflammatories to settle it, particularly if they can't even manage like a low load contraction and a low load isometric non-provocative contraction. They can't even do that. It's just super cranky. Then but I think in your chronics I'm reluctant to
What tips do you give people like to manage during the day? Like with sitting, is there anything? I know you like have a towel sometimes underneath your leg. I don't know how well that works.
Do you carry around a little butt towel?
You've got a wedge cushion. Don't you start with me.
I do, yes. So there are some little tips and tricks, but the basically trying to remove the compressive load on the ischial tuberosity. So there's lots of things people can do with their office chairs where they can like boost them up higher, shift them forward. So ergonomics has lost its mind with the whole you're short, so you have to have a footstool thing, and people end up sitting, they're sitting with their knees up around their shoulders, like typing away on a computer because they've got their feet up on a stool. So I'm like, get rid of the stool, put the seat a little bit higher, tip it forward, slide your bum to the edge of the seat, so your ischial tuberosity is off the chair. You're sitting on your sacrum on the edge of the seat. Yeah. Or slump more, like stop sitting so upright on your ischial tuberosities, get out of anterior pelvic tilt, like slump, slide forward in your chair, look super lazy.
I like
so they're
that one.
basic things that people can do, and
like
people are like, what? I have permission to like slump? And I'm like, yeah, slump work, and definitely move, like stand up, shift off it, or then there's offloading things like folding towels in various ways to create like a hole that your butt cheek drops into in the chair or in the car. The car is a classic, so all cars are built with this slight like tip back, so your butt's sitting slightly lower than your knees a lot of the time in the car. So I always say to people, make sure your thighs are sort of pointing downwards so your knees are lower than your hips. You can't do that in a car a lot of the time, so that's where the wedge cushion that's where the wedge comes in. So you can either get a wedge cushion or you can like roll up a towel and fold a series of towels into like a wedge shape to lift your bum up.
You get that from those like old mobility stores where you buy like 4-wheel walkers and stuff.
Yeah, you go and get your little butt pillow. Or just something simple like a little eggshell cushion, and you can sort of just literally cut a little hole out of it. Get a knife into it and just like cut a little hole for your butt cheek to sit into. So if your thighs, if the back of your thigh is supported but your ischial tuberosity is dropping into a gap, that's kind of what you want. Yeah. But obviously that's only a temporary thing. If you do that forever, like often your body has to adjust to
move. Short term.
Yeah, it's a short term fix for, obviously at some point you need to be able to sit on your hamstring tendon again.
Yeah. I love it. What to finish with, what tips? I guess I don't want to say tips and tricks because I don't like people to think of them like that. But what advice would you give to students and newer graduates and just anyone really dealing with any PhDs? And
good question. So I think we've covered a lot of tips and tricks, haven't we? But I think that understanding. I think so. For firstly, like young physios or physios that are looking to treat proximal hamstring tendons better, I think, understand the differential diagnoses and what certain tests you might be able to do to quickly rule in or out other things, or help guide how you might manage it. differently.
A thorough initial assessment almost.
Thorough, subjective. So because the subjective, a lot of the time, the subjective is the most important thing. So you should almost walk away from the subjective most of the time, being able to say, I think that's a proximal hamstring tendon. It could be this, it could be that, it could be that, and I'm going to quickly examine those things to rule out those other things most of the time. So there should be specific questions you can dig deeper in the history to get to the bottom of it. So that would be the first thing. Second thing would be test the hamstring in lots of different positions and then try and tailor your treatment in reverse. So start in the non-provocative positions. So I always get my patients to grade them. So I'm like, out of all those things I just did, what felt the worst? And sometimes people are like, oh, I felt so bad when you made me do that flick test thing. And I'm like, right, that person doesn't like maximal stretch and compression and flicking their leg out. So I'm going to finish there and I'm going to start in prone and go the other way.
Which makes a lot of sense.
Yeah, but some people are the reverse. Some people can do that and they don't get any symptoms, but you lie them prone and you get them to curl and they hate it. So you're like, right, well, maybe I need to start them in a slightly different position. They can probably start with their heels up in more hip flexion, where compared to someone who needs to start in full hip extension. And what else? I think that nailing your education and managing expectations is hugely important. So
that's a good one.
Always add time to whatever you think is going to be. So if you're thinking to yourself, tendon, we got taught at uni, if it's a tendon or, soft tissue injuries are 4 to 6 weeks, like, fuck off. I've never treated a hamstring tendon in under 6 weeks.
Yeah. Like if everything goes right, every single thing.
Everything goes right, you might
just get there. So I'll give you this exact time.
Yeah, correct. Yeah. You might have a little bit less pain and a little bit more strength at 6 weeks. But you're going to have to keep doing these exercises for probably 6 months. And if you want to be completely pain-free or at a level where you're really happy with your tendon, you're probably going to have to keep rehabbing this thing for 12 months. So depending on how cranky they made it with whatever flared it up, so that it doesn't keep coming back. And often that's a big sell as well. So I sort of say to people, a lot of the time these things come back because we sit on them all the time and because we stretch them all the time and because of the perfect storm of what's wrong with the anatomy, then often you have to see it through to the end, and the end is sprinting up hills. The things that we find are the most provocative on the tendon, they're the things I sort of tell the patient. I often draw them like a little staircase and I'm like, this is where you are at the moment. Boom, 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 these are all the steps we need to do. And you can cut out at any time you want. But if in the future you ever want to do anything up here, it's going to fall apart again. Like it's going to come back. So if you want to see it through to the end, these are all the things we need to do with rehab. And that's going to take a huge amount. Like that could take 6 months, 12 months, a long period of time. So I think managing expectations is hugely important.
Are you following up with patients like weekly or monthly, given the fact that it's a long one, or just depends on what they want to do? Or
it depends what they want to do, how quickly they're trying to rush back to something. Because I'm not seeing... I think if the person can wrap their head around my rehab and I'm confident that what I'm giving them they can follow, and so I'll often see them in a week, so I'll educate them, give them the blurb, talk to them about the do's and don'ts, and it's super basic advice, like the don't sit, don't stretch, don't poke, don't whatever, get a wedge, take some anti-inflammatories if it's super inflamed, here's some basic little ISO things, here's your shockwave, see you in a week.
Take this cortisone home.
Yeah, see you in a week, they come back in a week, and often they have some questions or something they need to confirm, or something else they want to tell me, by the way, I didn't realise I always sit with my legs crossed, blah, 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 and we talk about that. And then I would progress their rehab or show them what I want them to be able to do by the next time I see them, and often that's in a fortnight, and then I might see them in a fortnight again, and I'll do some re-checks of their strength measurements we did in session 1, and that's a really nice reassuring session. So maybe after 4-ish weeks, they might start to see some improvements in their strength, or in their, not strength, but in their tolerance of load capacity. And so I'm like, right, this is improving, super motivating, here's your next program. And depending on how quickly they're changing, it could be a fortnight or it could be a month. And then once I start seeing them every month, if they're making really good improvements and I can trust that they're going to follow what I'm going to give them, I'll see them monthly. But some people cut months too long. Like, if you see someone in a month and they come back and they're like, haven't done it, had COVID, was sick, couldn't get to the gym, whatever, and they've only actually had 2 to 3 gym sessions in that month, I'm like, no, not good enough. I need to see it more often. If you want to get this thing better, it's going to we're going to need to see you sooner.
Mm.
Whereas other people are fine. I can write them like a really complicated, complex gym program, and they go and they do it 3 times a week, and then they follow their running rehab program and everything. They come back in a month and they're better than I thought they were going to be.
Yeah.
So it just depends.
Yeah, lovely.
That was great.
Yeah, thanks for coming on, Nikki.
You're welcome.
Any parting words, quote, 1 sentence to finish with, if you did have anything to leave people with? I'll put you on the spot here.
We can always do this. I don't know. I look forward to the day that I don't have hamstring tendon pain. I do as I say, not as I do.
Yes, I say that to everyone as well.
I'm the worst. I'm the worst. I don't do any hamstring tendon rehab. But I cop it. I'm like, I know that my hamstring's shit, but I just deal with it. Yeah, I deal with it.
All right, and good luck for the marathon. And we might even post how you went, how the hamstring pulled up.
Oh, that'd be good. Yeah, a little follow-up.
Yep.
Good, thanks for coming on.
Thanks for having me.